You should be given the freedom to have that balanced information presented to you. A thoughtful and empathic oncologist or urologist knows these facts and would encourage you to weigh your options. There's never a rush. Cancer is a slow-moving train. And before you react to the terrifying news that you may have prostate cancer, your PSA is going up, or before you react to the result of that prostate biopsy showing cancer, pause in your thought and contemplate how you want to live. Hey everybody, it's Dr. Petteruti from Intellectual Medicine, speaking to you from South Florida. Today's topic, prostate cancer. Listen, I'm not going to bury the lead, so let me start out by saying my philosophy and my opinion and my clinical judgment based upon my research and experience addressing patients with prostate cancer and studying it in the literature. Here's my advice. There's no circumstance in which early-stage prostate cancer should be treated by conventional therapies, in my opinion. The evidence will support me in this, as I'm about to state. Treating prostate cancer in the early stages increases the likelihood of harm and has little to no benefit and may have none. There's yet to be proven irrefutable benefit in treating early-stage prostate cancer, and yet we plunge forward with biopsies, with radiation, with surgical treatment, with hormonal therapy interfering with a man's normal function. Now, what makes me say something so absurd, or not absurd, but so different? Treating a disease should be unequivocally beneficial to the host that has it. The treatment should never be worse than the disease itself. In prostate cancer, this is precisely what we are now discovering, and it's taken years to get to this point, decades even, where even conventional medicine is starting to acknowledge that the treatment pathways thus far utilized may do no good and may be causing harm. Let's start out with things that are irrefutably recognized. If prostate cancer has already left the prostate gland and gone into the lymph nodes or the bloodstream, it is no longer treatable by surgical excision. It is no longer considered a curable disease, at which point we are engaging in prevention of its progression. That's broadly accepted. You don't take out a gland in an individual that may have had it extend. It's hard to know if that's happened, but I'm going to go a step beyond that based upon, again, experience, literature, a little bit of common sense. This is going to be incumbent upon anybody that is contemplating how to deal with an elevated PSA or prostate cancer itself. What should you do next? Okay, so how do I come to the conclusion that I, for one, choose never to treat prostate cancer should I ever acquire it in its early stages? We'll set aside for the moment terminal metastatic disease treatment. In that setting, conventional therapy has some comfort measure intervention. However, we put that on a sidebar. The focus right now is those of you that may have had a nodule in the prostate, or may have had an abnormal MRI, or may have had a PSA that is elevating. Otherwise, you feel great. The treatment's going to do you harm, and there may be no benefit with the outcome. What kind of harm comes from treating prostate cancer? Well, let's look at surgical removal of the gland. I don't care how slick the surgeon is. I don't care how advanced the equipment is, Da Vinci or any other device. There's a risk of developing leaking urine. There's a risk of developing difficulty with erections or complete lack of erectile function. There's a surgical risk, infection. There's a risk of bleeding. There's a risk of post-operative or perioperative death. So you can die, you can leak urine, you can lose your erectile function. All this for little to no long-term benefit. In the short term, there's certainly going to be harm. Well then, how about radiation therapy? How about if you just irradiated that cancer? Well, once again, no evidence of long-term benefit regarding survival. there's potential for radiation damage that is delayed and becomes manifest years later. Radiation proctitis. The radiation can damage the rectum, causing it to become friable, irritable, weak, bleeding, leaking stool. Speaking of urine, it can damage the bladder. You can get a radiation cystitis, radiation damage to the bladder. And anytime you do radiation therapy for cancer, remember, folks, the radiation is carcinogenic, and it can cause and contribute to the risk of subsequent malignancies, specifically those doing with the hematology system, blood cancers, leukemias and such, non-Hodgkin's leukemias. So you got a definite adverse effect. Well, what about potential benefit? There's a compelling study that was published in a major medical journal within the last several years. It's called the Pivot Trial. In this study, all the men were diagnosed with early stage prostate cancer. Half of the group had the prostate gland removed. They had active treatment. The other half did nothing. The medical term for this is called watchful waiting. They give it that term because the term do nothing is a little bit unsettling. The notion that somehow they're watching it is intended to give psychological comfort and make it a credible pathway. We'll talk more about that in a moment and why I believe in augmented watchful waiting using functional interventions. So back to the study. Half had the gland out, half did nothing. What happened? They had the same death rate in both groups. And they had the similar, if not, they had the statistically same death rate due to prostate cancer. There was no statistically significant difference. There was a slight trend toward less prostate cancer death in the folks that had the gland removed, but it was minor if present at all. And that study was very compelling because it was done over many years. So treating early stage prostate cancer in this particular study, not shown to have benefit regarding survival. However, the people that had the intervention, the treatment group, if you will, had increased incidence of impotence, urinary leakage, adverse effects from the surgery itself. This is a dilemma. Listen, I feel the dilemma. We all, men, we all have prostate glands, and we know there's a high incidence of prostate cancer. They've done cadaveric studies. These were studies on men that had died of other reasons. And they looked at the prostate gland, and they found a significant number of them had prostate cancer buried in the gland. All right, so here we have evidence of little to no benefit, clear evidence of harm from treatment, and we have evidence of a high incidence of prostate cancer in a large cohort of men that were studied who did not die from prostate cancer. Gets a little bit muddled. So what's somebody to do? How about following a PSA? It's not been shown to correlate with prostate cancer, nor the risk of death from prostate cancer. I'll share with you a couple of clinical vignettes from my own practice. Gentleman had a high PSA. Surgeon did a prostate biopsy and told him, you have prostate cancer. We need to take your gland out. Patient said, no, thank you. I don't want you to mess with it. I like my quality of life. I feel great. Surgeon said, this is insanity. You're going to die from prostate cancer. Folks, that happened 25 years ago. The surgeon has since passed away. The patient is alive and well with prostate cancer, with no symptoms, with no metastatic disease. His PSA level, extraordinarily high, above 80, but he feels great. He went to a conventional doc, and the doc told him, you've got to go on hormonal ablation therapy because your PSA is going up. Androgen deprivation therapy is when they castrate you. They take away your testosterone because it might make the number go down. Is it going to make you live longer? We're still waiting for that evidence. Is it going to make you feel better? Heck no. You will feel worse. The androgen deprivation therapy corresponds with decreased muscle mass, decreased mood, increased body fat, decreased sense of well-being, diminished energy. You take testosterone away from a man, and you do him harm. So there's one example. Another example, gentleman had a prostate cancer surgically excised early stage. PSA is 0.1, non-detectable. One day develops back pain. Back pain develops into paralysis of the lower extremity because the cancer metastasized to his bone, causing compression of the spinal cord with a PSA that was non-detectable. Another case, gentleman with a PSA in the 20s, prostate biopsy showed evidence of cancer. Recommendation for active treatment. He opted out. He said, no, thank you. I'm going to keep my gland. That was about, 15 to 20 years ago. A subsequent biopsy done 10 years later showed no evidence of cancer. So what's going on? Is a PSA a reliable study? Biopsies worth doing? If a biopsy is going to be worth doing, you have to extend your thought to what would you do with the result. I've already shared with you my clinical opinion based upon the research and based upon my own clinical experience over 30 years of medicine observing patients with prostate cancer. These two sources of evidence combine to inform me to guide you away from active treatment, any conventional intervention, radiation surgery, etc. If that's the case, why even do a biopsy if the result is not going to affect a treatment decision? Before you subject yourself to a prostate biopsy, you should reflect upon, do you want to get irradiated? Do you want to have surgery to remove that gland? Reflect on that before you decide about a biopsy, because all a biopsy is going to do is tell you if there are cancer cells in the prostate gland. Now, it is my theory based upon the evidence I'm presenting that there's a cohort of individuals who have indolent prostate cancer that has been walled off and is stored, if you will, in the gland itself. It is possible that the prostate gland periodically makes cancer cells that never affect the life of the host, that never leave the gland, that stay in the prostate gland. And it's possible that if you muck them up, you stick needles in them, that you're disrupting that environment, that you're shedding prostate cancer cells that may correlate into a higher incidence of metastatic disease. That statement is my opinion based upon the information I've studied. It's not evidence proven, but it's logically ascribed. Think about it. You're putting a needle, and when they do needle biopsies, it's not a delicate or targeted procedure. It's oftentimes buckshot. They're going to hit a bunch of spots. Now, maybe they get the cancer, maybe they don't. So it's not a reliable study on that level. If they get the cancer, have they done you any good? There are studies looking at breast cancer, one of which showed that when a biopsy is done of a cancerous lesion, there's an incidence in some cases of cancer cells deposited along the needle track. There was another study regarding prostate cancer that gives us insight into the consequences of sticking needles in cancer. In this study, they had high-risk lesions in the breast. Some of the women opted for primary surgery without a biopsy. Just take it out. The other group had a biopsy first, subsequent removal of the cancer. The metastatic rate was higher in the folks that had the needle biopsy. It doesn't prove the point, but it's supportive of the theory that you need to be thoughtful about putting needles in nodules in cancer in the prostate, especially in the prostate, because the ultimate decision about treatment needs to be considered first. Now, if you listen to this podcast and you process my advice and you contemplate it for yourself, it is still okay to do a biopsy. It is still okay to get surgical treatment. And here's the rationale. It's because it's philosophy-based. If you can't sleep at night with the notion that there's prostate cancer in your gland and it's tearing you up, that becomes a reasonable enough approach or trigger to do something, even if the benefit is uncertain at best and possibly harmful. So this is a very individual decision. My advocacy is not for dogmatic carte blanche, you should never treat a prostate cancer in its early stage. My advocacy is that it is absolutely rational, reasonable, and potentially more beneficial to not treat it at all. But the information we really want doesn't exist. Nobody can tell you, if I take your gland out, you're not going to die of cancer. No, I can't tell you that if you leave it in, you won't die from cancer. I can tell you won't suffer from the surgery. I can tell you the evidence points towards support of the fact that taking the gland out may do little to no benefit. Likewise, radiation. What about a circumstance where they're following your PSA? The PSA is, the threshold, by the way, of a PSA is arbitrary. There is no strong indicator based upon this blood test about what to do next. So if you get a call back from your doc and your PSA went from 2 to 5, that oftentimes becomes a springboard to a biopsy. Timeout. You feel great. The number went up. The treatment is harmful, may do no benefit. Why are you going to stick a needle in that gland? My advocacy is to wait and consider, if anything, repeating the test at a later date. There are a lot of things that make a PSA go up. Stress, poor sleep, direct irritation, sexual activity, a long bike ride, an infection, free radical overload, a recent illness, a collateral illness that creates inflammation can make it go up. So go slowly down that path of sticking a needle in an otherwise intact prostate when you're feeling well. So what should you do? What about watchful waiting? Well, here's another piece of evidence supporting my advocacy that treatment causes harm and may do no good. Well, what is that evidence? It actually comes from conventional medicine. It is now accepted medical practice in the early stages of prostate cancer to do nothing. Watchful waiting. And that's because they know that early stage prostate cancer has a possibility of remaining indolent in the gland, never causing the host harm. Now, they have some other metrics that are utilized, the PSA level, an MRI of the prostate, something called the Gleason score, which is supposed to help them predict how aggressive the cancer is. All of these chunks of information can add some evidence to reflect upon, but none of them are directly correlating with a clear treatment path. In other words, if your Gleason score is unfavorable, it doesn't mean removing the gland is going to help you. If the MRI shows nodules, it doesn't mean that removing the gland is going to help you. That evidence is lacking. So what's a person to do? Conventional medicine, in essence, has endorsed the notion that treatment causes harm and may do no good for a lot of men with prostate cancer. If that were not the case, they wouldn't offer you watchful waiting or doing nothing. It would be unethical. But it is ethically reasonable to not intervene with conventional medicine. That has been broadly accepted. What about things that can be done that are unproven but not harmful, that have biological basis to believe they may help, and that can give us potential benefit, preventing that cancer, should it be there, from extending itself? Well, let's start with enhancing immune function. It's your immune system that kills cancer cells. It's your immune system that keeps it hermetically sealed, that prevents it from metastasizing. So supporting immune function. In functional medicine, anti-cancer supportive care, mistletoe therapy, often used subcutaneously, is gentle, safe, and may have that effect. High-dose intravenous vitamin C has been shown in lab studies to kill cancer cells. Theoretically, it is the use of high-dose vitamin C for the hope that it may be killing cancer cells in your body as they are floating about. It's an unproven theory. But here's what I know for sure about cancer, and about vitamin C. Given intravenously, it'll do no harm. It's extraordinarily safe. supportive of immune function. It's an essential water-soluble vitamin. How about addressing other carcinogens? Heavy metal testing, provocative heavy metal testing, can reveal how much toxic metal has been stored in your tissue. Cadmium in particular is carcinogenic. Other heavy metals, arsenic, aluminum, perhaps even lead, can instigate and contribute to cancer risk. Lowering those heavy metals via chelation may have value, not only to reducing the risk of cancer, but other health benefits as well. And it's harmless. It's not going to cause you any pain. Percent body fat. Listen, take a tape measure, put it around the thickest portion of your waist. If it's above 40 centimeters, that's a risk factor for heart disease and cancer. Fat cells are contributory to cancer risk. So let's get focused on that as well. Not reducing your weight, but reducing percent body fat. Certain supplements may have value. I like keeping the vitamin D level of my patients above 50, and I like having their zinc levels in the upper quartile of the range for the lab. The zinc is highly concentrated in the prostate gland, supports immune function. Vitamin D also correlates with better immune function in many studies. So as we bring this to closure, folks, reflective of the option of doing functional intervention in the face of early stage prostate cancer, in my opinion, should be seriously weighed against the risk of toxic intervention, harmful intervention from surgery and radiation. You should be given the freedom to have that balanced information presented to you. A thoughtful and empathic oncologist or urologist knows these facts and would encourage you to weigh your options. There's never a rush. Cancer is a slow-moving train. And before you react to the terrifying news that you may have prostate cancer, your PSA is going up, or before you react to the result of that prostate biopsy showing cancer, pause in your thought and contemplate how you want to live. How do you want to fight this cancer? Sometimes I describe this as fighting prostate cancer like a man, not sacrificing your vitality in what may well be a futile hope for grabbing some longevity. Quality and quantity both travel together, but we always place the emphasis on the quality. That is reassured. Longevity, philosophically variable, right? We'll end up in the same place. Well, folks, thank you for listening. I know this is a complex topic. We'll come back and talk about it periodically, as well as highlighting case studies along the way. Dr. Steve Petteruti, I'm a board-certified family doctor. My focus is on anti-aging primary care, functional medicine support. Thank you for tuning in to Intellectual Medicine, and we'll be seeing you soon.